world. This is our sixth, in fact, VIP webinar in 2022. I'm very pleased to host a Fulbright scholar visiting University of Newcastle, professor of neurology, Jennifer Majersik. Apologies for the pronunciation. If I got it wrong, Jennifer, please correct, from the University of Utah. Jennifer obviously has a great deal of experience in many areas that refer to neurology, but I would say that in her research and also in her Fulbright scholarship, she's focusing on, in particular, on telehealth with a focus on stroke. So she will focus on the US finances, policy, and law or legal aspects from a clinician perspective. It's a pleasure to have Jennifer here at the University of Newcastle. She's been directing the director of the 6-state, 26-site Utah Telestroke network. She has been conducting research on stroke in the healthcare system, in the US system in particular, for a very long time, and she'll be with us in Newcastle for a couple more months, I believe. So this may also be an opportunity to connect with her. And before handing over to Jennifer, I would like to ask everyone who's attending if they have any urgent questions. Jennifer is happy to take them on board while she's presenting. Please write in the Q&A or in the chat box, which I will monitor, UQ, urgent question. If you can't wait until the end, you can start typing and just put a Q in front of your question so that I know what's what. And basically, I just want to welcome everybody and also indicate that we will post this talk on our website, and obviously the recording of it will be also part of our next newsletter for those who can't attend today. So Jennifer, please take it away. Thanks.
Thank you very much, Francesco. Can you hear me okay? Just want to make sure.
Perfectly, yeah.
Okay. So I do want to acknowledge before I get started that I'm today in Newcastle on lands traditionally held by the Awabakal and Warrini peoples, and I pay my respect to the elders past, present, and emergent, and celebrate their diversity. And today I took part in something I've never done in the US, which is a SARI day at the Hunter Medical Research Institute, which was a new experience for me. So I was appreciative of everything that went into that ceremony today as well. I have no financial disclosures that are relevant to this talk. So I'll give you a little bit of personal background today and a little bit about the Fulbright, because I think it's nice for people to know what that's about. I'll talk about US healthcare finances and structures and a real primer, meaning a basic level. And then try to explain what Telestroke is, because I know the audience here is a little mixed between people who know about healthcare policy and then people who know about stroke. And then various Telestroke structures, how finance works within the US, as well as the regulatory environment, and then what the effects of the pandemic have been. And try to end with what I think the future will hold, which is actually pretty cloudy. As for my background, as Francesco says, I'm a neurologist specializing in stroke. I'm at the University of Utah. And I run both the Telestroke network there and then also a clinical trial stroke network that goes throughout our Intermountain West. A lot of people don't know where Utah is, so I put this map here with a big star for where it is. So Colorado is here, California is over here. And so we're in this big mountain range here. So it's a beautiful area if you ever want to visit. And what I'm not is an economist or a policymaker or really an expert in most anything I'm talking about today. So if anyone is any of those things and they say, that's not quite right, I will humbly accept your opinion over mine. So bear with me as I stretch myself a bit and try to explain things that I'm not an expert on. And then just briefly about the Fulbright, I'm not going to read all of this, but it is a pretty cool program. It's the flagship foreign exchange scholarship between the US and actually multiple countries, but Australia was the very first one that the Fulbright Commission had a treaty with. And I learned it's the first treaty Australia and the US ever had together, was the Fulbright Commission. It's now in over 160 countries, and they take students and academics and professionals and implant them both ways, both in the United States and in Australia. And really, it's supposed to be a process by which both Americans and persons from other countries come to understand each other more. So it's in the spirit of that I thought I would try to share something about the US healthcare, and particularly because Francesco has been very generous with his time trying to explain to me the Australian healthcare system. So there you go. All right, so here's my primer on US healthcare organization and finance. And I took a lot of this from sources on the web, and I've cited those just so you know where they're coming from. So in general, the US has over 330 million people, and it's one of the most complex healthcare systems in the world. And I love the quote that I had, it's in a constant state of evolution, which explains how I'm constantly confused as a clinician. As everybody knows, there's no universal coverage. It's a mixed system. And there was briefly a law saying that an individual has to be covered by insurance, but it was shot down by the Supreme Court a couple of years ago. So the coverage is an intertwining relationship between providers, payers, and patients. And we do have publicly financed government healthcare called Medicare and Medicaid, but that coexists with privately financed or private health insurance plans and their market coverage. So the market provision of coverage and out-of-pocket payments predominate as the financial means for providing healthcare. And I'll show you some percentages on that. I liked this slide that I found on the ISPOR website, which is a great website for learning more about healthcare. On the left here, you have private households. On the right, you have people like me, providers of healthcare, so nurses, doctors, pharmacists, et cetera. And this is how money flows. I'm not going to go through every arrow here, but you can tell people pay taxes. And then that goes to state government, which funds Medicaid. They pay federal taxes, which goes to the federal government, which pays for Medicare and also Medicaid. But someone like me, I'm not eligible for either of those. I'm not old enough to be in Medicare, and I'm not impoverished enough to be eligible for Medicaid. Therefore, I pay, my employer pays me, but I also pay a chunk of my paycheck that goes through the employer to help pay for private health insurance. And so I pay part of my insurance myself each month, and my employer pays part of my health insurance each month. And then the providers of healthcare over here, we take all of these things. So it's a little bit different in Australia, where different hospitals may take one type of insurance or another, or different providers. But for us, it's pretty rare for a provider to not take both private and federal insurers. And so there are some that you may have certain hospitals that have preferences for certain private insurance over another, but basically all hospitals take Medicare and Medicaid. And then there's some out-of-pocket things that I'll describe, I think, in 2 slides. So in terms of how this breaks down, in 2019, about half of US citizens received their insurance, like myself, through coverage through their employer. That's called group insurance. 6% got it on an open marketplace, which means they pay for it no matter who employs them. It's not employer-based. 20% have Medicaid, 14% rely on Medicare, which I find very interesting because Medicare is really what drives healthcare policy. Like what they fund and don't fund is what drives what private insurers will fund and don't fund. So even though it's a minority of the patients in the US, then 1% have other things going on, and 9% are uninsured. And I just threw this up here to show you that in the past, a much higher percent were uninsured. And then when what we euphemistically call Obamacare, but is technically called the ACA, or the Affordable Care Act, when it came in, the number of uninsured dropped quite a bit. And it has been climbing a bit because of what I mentioned before, which is to say that there's been some federal action that has sort of chipped away at the Affordable Care Act, meaning that not everybody's required to have health insurance anymore. And there are a few other changes as well that I won't get into. All right, so out-of-pocket spending, that's something to keep in mind. So this is stuff that I personally pay for, or someone in my situation. So the types of things that you can pay for if you are insured is that you would have a monthly payment for your insurance. That's a premium, so I pay that. And then a co-payment is the fixed cost of a service. So if I want to go to the ER, I should have to look, but I think my copay is $100. And if I went to see my primary care for, an injured knee or something, it might be $10. Often preventative medicine doesn't have a copayment. There's also co-insurance where you're paying a proportion of the total cost, and then a deductible. So deductible is very common in plans, and the higher the deductible, the lower the whole overall insurance is. And what that means is that you're responsible for the first several $1,000s of your bill that year. So if your total bill for the year is 50 grand, you might have a deductible of 2,000. And so one thing I get as a provider is requests to complete people's services before the end of the calendar year. They say, well, I already paid my deductible this year. Can I get that MRI before January? And for me as the provider, it doesn't matter to me when I order the MRI. So we'll get it in December so that they're not dinged on they've already paid their deductible, if that makes sense. And then if you're uninsured, you're supposed to pay the complete cost of care, including what insurance companies would normally pay. I can tell you that obviously, but it doesn't always happen. And so hospitals will end up eating a lot of that cost for the uninsured patient. For outpatient care, not so much, because they're not in the same situation where it's an emergency, so they're not required to see those patients. So in 2019, total out-of-pocket spending for the United States was $406 billion, which is about $1,200 per person. Clearly not differential. It's going to be differential. Not everybody will have the same amount. Okay, hospital financing. This is complicated. So as I mentioned before, all hospitals receive payments from both public and private financing sources. So we accept patients from both types of insurers. And then hospitals are paid through that insurance through something called a DRG, which is a diagnostic related group. It's determined by CMS, which is the group that runs Medicare and Medicaid. And they assign a set payment for a particular disease or condition. And it doesn't matter what it actually costs the hospital to manage that condition. This is the X amount of dollars that they're going to pay. So they're going to pay an X amount for a hip replacement or for a stroke, which is my specialty, or pneumonia, or whatever it happens to be. So the hospital does not submit like a line-by-line reimbursement for procedures and medications. Now, there are some caveats to that. If the patient has higher complexity, there will be higher reimbursement. So if they have renal failure and stroke, I'm kind of making this up because I don't know exactly all of the high complexity things, but I'm pretty sure renal failure is one of them, or heart failure, then the DRG would pay higher. So the DRG payment is to cover the accommodation costs, i.e. room, board, heat, procedure costs, all support staff, drugs, and medical devices. What it does not cover is physician fees. And so I'll go over that in a minute. In general, private insurers generally pay more than it costs the hospital to provide those services. And then Medicaid and Medicare, and obviously uninsured, pay less than it costs us to provide those services. So speaking of physician fees, and I told you this would be from the perspective of a clinician. So our physician fees are not included with that DRG, whether it's an inpatient or outpatient. So we bill separately. And when we bill, we use codes that are literally billed under our name rather than that of the hospital. And we bill a level of service. It's kind of like a 1 through 5 or a 1 through 3, depending on what it is, as how much time it took us. And they, not just time, but also complexity. And they all are related to something called a work RVU, which is something that I didn't understand when I was a trainee, but it's a relative value unit. And it compares different, so you might have one service that's a 1.0 RVU, and one is a 2, and one is a 9. And so the more complex services and the more longer ones will have higher work RVUs, and they will reimburse more. And so you can imagine there's a committee, I think it's called the RUC, that sets these work RVUs, and that will determine physician payment. So I don't choose how much I bill, other than that I have to be honest, otherwise it's fraud. It's considered fraud to say whether I did a level 1 or level 3 service or whatever. And then I put in the appropriate code, and then how much that equates to a dollar amount is determined by an external body. And we use this kind of formulation for all insurers and for both inpatient and outpatient. And we get a lot of training in how to do this because it's a little complicated. All right, and then there's regulation, of course. So federal healthcare laws are run through Congress, but there's a huge part of it that's a regulatory thing, and that's the Department of Health and Human Services, or HHS. And they're really responsible for interpreting and enacting the law that Congress has set. And they do that through many different agencies. So the FDA, which you've probably heard of, CMS, which I just mentioned, NIH, which runs grants, AHRQ, which also runs grants, and then CDC, which is public health. And so there's a lot of regulatory stuff going on, a little bit horrifyingly large amounts of things. And then there's another group called that accredit hospitals. And I threw this in there because it's particularly relevant to stroke. Currently, there's 3 bodies that can accredit a hospital. The hospital gets to choose which one they want to use. The most common one is Joint Commission. The second is DNV, and the third is this HFAP. And they will accredit hospitals to say that they are a safe and worthy place to get care. And they can also do add-on certifications for different diseases, such as heart failure, and in my case, stroke. So they will designate hospitals as an acute stroke ready hospital, which would be a small one that is can manage patients in the ER, but after that they would ship them out. Or a primary stroke center, which can do IV thrombolysis, and I'll talk about that in a minute. And then a comprehensive stroke center, which is what we are, which can basically do everything, much more complicated care. And so a large part of my job is actually managing the hospital accreditation process and making sure that all the things that we do are in alignment with what they require. And then this is something that I don't think Australia does, and that you guys can correct me if I'm wrong, but because of these certification processes, and because hospitals are businesses, even though they're not for-profit businesses, we end up with a lot of people kind of touting how great they are. And so I just pulled some ads that I found on the internet, but why choose Johns Hopkins for your stroke center, or Northwestern or Providence I put up there. We do the same thing at the University of Utah. We want people to know that we're great at stroke care, and then for them to come to us. And then there's this ranking, US News and World Report, that does rankings of hospitals every year, and people care a lot. Where are we on the ranking? Are we 1, 20, 50 or whatever? And so all of this becomes kind of a competitive thing, both in your region and in your country. All right, so not to leave out states, of course, there's 50 states. States can pass additional laws as long as they don't contradict the federal laws. And because states run Medicaid, which is the program for persons who have low income, the state regulations particularly affect Medicaid. I found this paper that's listed below that talked about stroke care, and it showed that as of 2018, 39 states did have some sort of additional regulation regarding stroke care, whether it was designating stroke centers, or routing of ambulances, or of having other policies. And so this would be the same for any disease, but in my case for stroke, this is also something I have to pay attention to. All right, so we're going to switch gears to the clinical thing. This won't take me too long, so for all of you non-clinicians, don't fret. So stroke is a big problem. I did not define it here, but it's basically when the brain arteries either are clogged or break open. And so either you have an ischemic stroke with not enough blood, or a hemorrhage stroke with too much. Almost 800,000 patients have a stroke in the US every year, and we have a lot of survivors, and it's very expensive. So we talk about really needing strategies to improve healthcare while decreasing costs for stroke. And this is not unique to the United States. This is the same in Australia or any country you look at, with actually the problem being worse in low-income countries than high-income countries for many reasons that I'm not going to get into today. I like this very simplified diagram. It allowed me to remove multiple slides. Basically, the point is that there is acute stroke care, and there has been for a long time, but it's gotten even better. And we have a time clock that's ticking very rapidly in order for us to give either alteplase, which is called TPA, generally within 4.5 hours of the stroke, or out to 24 hours to have clot retrieval. And so that means they actually go to a comprehensive stroke center, like here at the John Hunter, or in my case, University of Utah, where they take a catheter up and then pull the clot out. And these treatments are difficult to do and require a lot of expertise. And they also require a lot of systems of care. So we'll get into that. Generally in the US, and I know this is also true for Australia, that these treatments had been historically pretty underused. In 2009, only 5% of stroke patients had TPA, but we've done actually a pretty good job. And by 2018, we're up to about 12% of stroke patients. And then thrombectomy, that clot retrieval thing, was at under 2% and is now up to almost 6%. But we do have a lot of disparities, including geography. So rural hospitals are far less likely to get stroke expertise, and less likely to get IV TPA, and less likely to have thrombectomy. So this map is something that I think can kind of help you understand. This one was done, this was 2014, and I assume the map would look different today, but the dots are the population density. And then the gray is where people are within 60 minutes of driving or flying to a place that can give TPA. So this isn't even for thrombectomy, just the drug in the vein. And then the white is all places where they are more than 60 minutes away from a center who can provide this care. And so keep in mind, I live right in here in this heavy gray area, but this is why we serve, and I'll show you in a minute, this whole area, this big area that doesn't have expertise. And I haven't mentioned this yet, but the people who decide about giving TPA generally are neurologists. And so that brings me to this slide, which is the problem of not having enough neurologists in our country. And this looks at all things, not just for stroke care, but it shows you their estimated supply and demand in 2025, with most of the country being underserved in neurology. And I would assume it's the same in Australia. This is particularly an issue because of the rising prevalence of Alzheimer's and stroke and other diseases that particularly affect the aged. But what it means is that there's not enough of us to go around. So when you have these big areas of patients who have need, we don't have enough neurologists to manage the need. So that led to this thing called Telestroke, which is we had at the time really good treatment and we don't have enough access to it. And so a Telestroke system is came of being and became much more popular. It's a way to provide stroke expertise to remote sites who don't have neurology in general, nor vascular neurology at all, to allow rapid evaluation and treatment. And I have a couple pictures here. This one's the back of my head. This is the front of other people's heads. This one I took just from the news, just opened in Blue Mountain just last week, I guess. This is a super old picture for me here, but we provide live audio video link up within minutes of the patient and their emergency physician requesting it. And I've been touring some of the sites here. It's basically done the same here in Australia as it is in the US, which is to say that the stroke neurologist is on call. And when they get the call, they wire in and try to provide the best care that they can. We can talk more about what that looks like if you want, but that's the basic gist of it. All right, so this paper came out in 2020 and included us in it. This is showing the number of hospitals in the US incorporating Telestroke by year. So this isn't that some people got rid of it. These should all be stacked on top of each other. So a few in 23, a few in 2003, and then more and more and more. And all of this adds up to about a quarter of US hospitals now having Telestroke in their emergency departments. And then keep in mind that probably 50% of hospitals are certified themselves to provide stroke care without Telestroke. So it's not that 3/4 don't have stroke care, it's that a quarter of them are using Telestroke to provide that care. So it's a very popular solution. The ones that have Telestroke are larger, more urban. They tend to be in the West where I live, and they tend to be in counties with fewer neurologists per capita. So it makes sense that they're in counties with fewer neurologists, but it doesn't make sense that they're in the urban and bigger areas. This led to, I like this quote, Telestroke is the largest, most substantive and fastest growing telehealth intervention of the past decade for acute stroke treatment, in which lack of access to stroke expertise placed, thrombolytic therapy out of reach for many patients. Turns out that's a tongue twister. So I'll just show you our network real quick. This was it in 2005. I don't know who chose this color scheme, but it makes me laugh because it's so ugly. We had 6 rural sites, and in 2005, we had 16 consults. 2006, we had 41, so we were really small. And this is us more recently. We've expanded so much that we had to make the map a lot smaller. This is Montana, Idaho, Wyoming, Colorado, Utah, us, and then Nevada. We have many, many more sites. I just have a few pictures of some of our sites. This is Bozeman, Montana, where there are 3 neurologists. Davis Hospital is actually right up the street from us. And then Carson, Tahoe, Nevada is way out west, and they have 1 neurologist. These are what we call our urban sites. And then we have what we call critical access hospitals, which would be just very, very rural, as you can tell here. Vernal is one of my favorite places. It's where the first T-Rex was found in the United States. And so it's because it's oil country, and so bones are well preserved. So they have a big pink dinosaur when you get there. And my friends are visiting there tomorrow to do stroke education. So I'm excited about that. Blue Mountain, Utah is a beautiful place. This is Monument Valley down here. It's a really tiny little hospital. And it's kind of funny because you guys have Blue Mountains too. And I had a bunch of other photos, but I took them out in the interest of time. So this has been our growth just since 2014. You remember I told you we had like, I don't know what I said, 40 consults back in the early aughts. Now last year we had 1,600. And we've continued to increase in sites, although we've kind of probably peaked at around 30 because we have most of the hospitals that are in need, at least within our region right now. So all of this tells you that telestroke is really wanted and valued. All right, so let's talk about structures of telestroke. It's a little bit of a busy slide, but I think it allows me to pause for a minute. The most common structure is the one that we have, which is called hub and spoke. And that would mean that myself at the University of Utah and my colleagues provide consults to all those hospitals I just told you about, and they generally ship patients back and forth between us. That's mostly what the John Hunter does as well. In 2012, when there was a survey, this was the most popular method. I actually don't know what percent it is now, but it'll be less. And there's something called a distributed model. And these include for-profit telehealth companies, which are pretty popular right now. And I think some physicians really like working in this model where all they do is telehealth. And so in that case, someone is providing telestroke, but they're not affiliated with the Comprehensive Stroke Center or the big hospital, nor are they affiliated with the spoke. They are providing a service, and then it's up to the two hospitals to decide how they're going to transfer patients, but they wouldn't go to the third party because that party doesn't have a hospital. They're like sitting at home and unaffiliated, and they could be anywhere in the country or world. And then there's what we like a network model where you have maybe not enough neurologists to take call for every hospital. So they all pool together and will support each other. And I wrote this is popular in the United Kingdom. I think it's also popular in New Zealand. And it's happening a bit here in New South Wales as well with the current telestroke model. And so in that case, you might have multiple hubs and multiple spokes, or they're all hubs, but they're covering each other. So I think I might skip this because I know I'll run out of time and I was worrying about it, but I'll just say that there is going to be a lot of structural change in the future with this, where the concept of a spoke and hub is not quite as clear because with the rise of thrombectomy, more and more hospitals are trying to become competent at doing that. And so it's changing how we're structuring stroke care. And I'm certainly seeing a lot of change within my region in terms of that. All right, so when we're talking about finances, I want you to start thinking about how much work it is to set up a telestroke program like this. So there are operational concerns. You have to do a needs assessment, figure out if a hospital needs it. There's institutional alignments that probably need to happen. And then of course, at least in the US, you need contracts that you need to have legal involved. You need a clinical team, you need a stroke neurologist like me and a director. You have to design protocol and order sets and do trainings, both initially and ongoing. And that needs to include emergency medical services. And then there's all the technical stuff, the cameras, the computers, what we call the line. That one of those hospitals I showed you, we tried to start telestroke there previously, and their town didn't have enough bandwidth. And so they literally had to get a new internet line that went to the hospital before we could start. So there's a lot of rural places in the United States that do not have enough internet. And then hopefully you're measuring quality and have an improvement team helping you with that too. I just put this up here to say that we at the U are doing all this with not just telestroke, but with a lot of other programs as well. So all these dots are other telehealth things that aren't necessarily stroke. And you can see all the different programs that we have that are doing telehealth. So that helps me because it's allowing my program to be embedded inside of a larger program where some of that infrastructure is already built. So this is how our organizational telehealth structure looks. We have a development, project management, technology, and operations. And it is an internal structure to try to ensure the success of all of our telehealth programs. All right, let's talk a little bit about regulation, our favorite topic. I pulled a bunch of stuff from the Center for Connected Health Policy, which is a national telehealth policy resource center, like it says. But actually, it was great because it had a lot of information. And the little bubble up there on the left, I liked, says telehealth policy trends continue to vary from state to state, with no two states alike in how telehealth is defined. reimbursed, or regulated. General definition is use of electronic technology to provide healthcare and services to a patient when the provider is in a different location. And so just pointing out at the top there, so 43 states and the District of Columbia, where our capital is, have laws that govern private payer reimbursements of telehealth. But that means 7 of them don't, right? And then 21 of those states require payment parity. This is a big deal. And this means that an insurer will pay the same amount for in-person care as they do for telehealth care. And that's something that is obviously not common, although it's almost at half of them now. And then you can see various things that they kind of track, like how much, what they're reimbursing for. And this, of course, it goes beyond just stroke, but telehealth in general. So it varies a ton, is the bottom line. And then medical licensure and credentialing is also a really big deal. And I told you this is a clinician's perspective. This is something that affects me a lot. So we have to be credentialed at all hospitals we work in. And that means all 29 of those hospitals I showed you, I have to be on the books as being a provider for those hospitals. We try to use something called reciprocity, where they will believe my hospital that they have gone through all the credentialing work. And credentialing includes just making sure that I am who I say I am, that I'm doing my continuing medical education, that I don't have lawsuits pending against me, things like that. Or some of our hospitals will not do reciprocity, in which case we have to go through this process every year, which is pretty onerous. And then second, we have to be fully licensed to practice medicine, unfortunately, where the patient is at, not where I am at. So if I do a telestroke in Wyoming, I have to have a full medical, or at least a telehealth medical license in Wyoming. And that is a big issue. So I have 6 medical licenses, and it takes thousands of dollars a year to keep those renewed. And each one has different requirements for for how to get your license. My favorite crazy example is that Nevada, which is known, it has a lot of federal land in Nevada, and a lot of testing goes on there. And so I think they're a little bit afraid of being a target in some, large scale war. And so to get a medical license in Nevada, you have to have, it was something like 6 hours of bioterrorism training, which I'd never had. So I had to do 6 hours of bioterrorism training to provide Telestroke, which is not related to bioterrorism at all. So you can understand it gets to be pretty complicated and a little unpleasant. There is a concern that state licensing boards are more focused on protecting like turf. So a physician, like where we work, and like, I don't want someone from Massachusetts coming in and taking my job, that kind of thing, rather than the public's interest. So for example, during the pandemic, and I'll show some data on this, but when patients were doing primary care visits with their provider, if their provider wasn't licensed in the state they lived in, the patient would drive to that state where they are licensed and like sit in their car and do it from there. Kind of crazy stuff. I was talking to someone from Missouri who said her patients who were right over the line in Kansas would literally drive to Missouri and then sit in the McDonald's parking lot or wherever so that it was legal. You could argue that what probably wasn't necessary, but that's the kind of thing you get into if you're not licensed. So there are a lot of proposals to ease these licensure burdens. One of them is to expand something called the Interstate Medical Licensure Compact, which has a cross-statement agreement. And it varies a little bit from reciprocity. And I'm not going to get into it, but there's a lot of data out there about it. One is to license us based on where we are instead of where the patient is, but you do get into that turf battle thing. And one is to implement a federal license to practice medicine. And I don't think anybody thinks that's actually going to happen. This is a picture of the Interstate license, or the Medical Licensure Compact. Oh yeah, Interstate Medical Licensure Compact, and what the member states are. And while it kind of looks like, hey, this is really taken off, you can tell I actually helped lobby for us to do this, because you could tell it includes all the states I'm licensed in. But think of where our population centers are. So California is not a member, Florida is not a member, wherever New York, Massachusetts, Pennsylvania, these are big popular states, and none of them are part of the pact. This just tells you again that how the states are licensing and how many different parts of them are in compacts for not just MDs, but also for other professionals. So occupational therapy, registered nurses, et cetera. So again, really complicated and moving very quickly. All right, financing of Telestroke. Took my time. I'm doing okay. All right, so I talked to you a little bit about what it takes to set up a Telestroke network. So the costs, right, both startup and maintenance. We've already talked about technology that has a very variable cost. And in fact, we at the University of Utah recently designed our own cart and technology, so that because we thought we could do it cheaper. And we designed something that we could also control so that when it broke, we weren't waiting on a third party to come fix it, the internet connection. And then you need all that programmatic support that I was talking about before, including IT support. So we now have something called a guardian angel that helps us. And you can guess my age if you want, but let me just say I'm old enough that I get a little frazzled when things go wrong. And now there's literally an IT person taking call with me and who is on camera with me off to the side. And we'll say, oh yeah, I can tell the audio is not working, and they'll fix stuff for us. A business administrator, quality team, et cetera. And then the provider. So we do want to be paid for our time, and I'll go into that quite a bit in a few slides. And then there's all that credentialing and licensing that I was talking about. It's actually a lot to keep track of. It's hard for me to remember who I'm credentialed with and not. And so someone else is doing that for me. But the opportunities are huge. So you can improve your patient care across the region. For the entire healthcare system, there's no question, but Telestroke is cost saving and cost effective, which it's not the focus of this talk, but there's been a lot of work that's been done to show that. You can retain patients at the community hospital that don't need to transfer. In the past, when I did everything by phone, I would just say, yep, transfer, 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 which is very expensive and probably not always necessary. And then on the flip side, you can help the hub hospital, so the larger one, keep its doors open for more complex patients. It is awful to be the doctor trying to accept patients and say, I don't have room. And I know your patient is really, really sick, but I can't take them because I have no space. And so this allows us to transfer the patients who should be transferred and not the ones who shouldn't. So done correctly, it sounds like a business speak, but you can have a win-win-win-win situation for everybody involved. So sorry, my slides do that. Thinking about spoke hospitals and hubs, so the small hospitals and the big ones. These are things that I don't think affect Australia quite as much because of your different system, but maybe I've explained to you enough that you'll understand this, that a small spoke hospital has often very tight financial margins. And keeping some of their patients can actually mean the difference between them closing and them staying open. So having a big cost outlay is not going to be something that they're that interested in because they don't have a lot of margin. But often they're not the ones carrying the major burden of the Telestroke network because, like I said, it's mostly the hubs doing that work. They do, however, have some benefit to being aligned with larger health systems. When they have better collaborations with those systems, that often works in their favor for various reasons. And then the hub, often it's going to cost them more because we're the ones setting it up. But we also have a financial upside to this, which is to being able to accept more complex patients and not be admitting patients who are low complexity. That's because the margin is lower on those patients. All right, so how do we support Telestroke? I call this income. That's probably not the right word. If I was a finance person, I would use something else, I'm sure. But that's how I think of it. How does money come into a program? So we can start with per patient billing, otherwise known as insurance. Both public and private do pay for some telemedicine and for Telestroke. And I'm going to go into that in a few slides. For the physician part, which I told you is separate. And then the hospital billing is an issue. There's very, very little insurance reimbursement for the hospital part. I shared some of these slides with our telehealth network manager back in Utah. And he said, don't forget, we don't get any of that money. Like the hospital itself doesn't share in that billing. And so that makes it difficult to grow a program. There's what are euphemistically called institutional resources. That would be the margin. So if a hospital is making a little bit more money than they're spending, that can be put back into a program. There is sometimes state support, like incentives to rural hospitals to start up such a program to improve care. There can be state and federal grants that can be applied for. There's philanthropy. We have more than one site that was started by a generous donor. And then the most common one, and that's what I've listed last, and that's what we rely on at the University of Utah, is that the spoke hospital actually pays fees to the Telestroke organization. In our case, it would be the hub, but it could be to a third-party Telestroke purveyor, like I was mentioning before. Generally, That is going to be a lot cheaper and more feasible than hiring a neurologist or neurologists to work 24/7. And generally that fee is based on volume. Sometimes it's a per click, meaning every time you call a consult, they get charged a certain amount. Or it can be both. There can be a baseline volume that's paid every month and then a per click on top. And I am involved in this a little bit because we try to talk about what our time is worth and what we think we should be paid, but mostly this is run by the hospital and the contractual part of our organization. So this got really messed up. Sorry about that. Go back. Physician contracts. So this varies a lot in how it's done. So how does the MD get paid? Most of us are going to be paid by our hospital or our physician service organization. And this is specifically for Telestroke I'm talking about. And we might be paid like a call stipend, like I'm going to be paid X amount of dollars to work 12 hours and take whatever comes. Or I might be paid work RVUs. Remember I was talking about those for every time I do a consult. So I get 5 work RVUs and that's reimbursed somehow down the line. We might participate in traditional billing and say we're actually going to bill insurance, so CMS and private payers. But I will tell you that when we do that, the billing is paid as if it's an outpatient visit and it's based off time. And so if it takes me 30 minutes to do a telestroke, I'll be paid as if it was a 30-minute clinic visit, which is actually very little money. It might be like $100. And considering the high acuity and that this is happening at 2 in the morning and I had to respond within 5 minutes for an unscheduled event, I think for most of us, we would find that that payment is not adequate. And then it also might just be what we call percent FTE, meaning, Jenny, you're supposed to work, I'll say 40 hours a week, which is less than I work, but 10 of those 40 hours are going to be doing this. It's like, okay, that's how I'll spend my time. And so it's really just that I make X amount of dollars and then some fraction of that I spend doing this work. So there's a lot of different options. All right, so I think this thing also for some reason, sorry. This slide is a little bit old, but I put it up here so you can understand what we've gone through in the recent years. This is what CMS, remember Medicare and Medicaid government insurance, requires for us to bill for telestroke. And this has since been changed, but this was what we did up until just a couple of years ago. And the big thing was that the site, the hospital that needed the telestroke consult, had to be located in an urban, or sorry, in a rural or frontier area. They could not be urban or suburban. And that's what a metropolitan statistical area is, which you can ignore, but it had to be in a rural or urban area. And then the patient themselves also had to be in a hospital. They couldn't be at home. So this caused a lot of problems for us. We basically couldn't bill Medicare for any patient who was in a city. But 94% of strokes happen to patients who are in cities, urban or suburban. And so for years, we were pushing Congress to change that. And I have a little picture in the corner. There's me and a whole bunch of us from Utah, including my son, who really had a bad haircut, but he's just a sweetheart. And so this is my Congressman Stewart. He still is my congressman. And a lot of us went to what's called Neurology on the Hill. And we went every single year for many years to explain the problem and to say we wanted there to be an expansion of CMS to allow for telestroke, even to urban payers, even to urban patients, I mean. And so that was first the FAST Act, furthering access to stroke telemedicine. And then it got roped into something called the Chronic Care Act, which was actually put forth by our just recently deceased Senator Hatch. And that was to eliminate geographic restrictions on telestroke, among other things. And so there were a lot of us out there trying to make this happen. And it did. So we were very excited. In 2018, it was signed into law by President Trump. And so we were finally allowed to bill for telestroke services for patients even in urban areas. All right, briefly, COVID and telehealth. I think probably most people know that telehealth just went bonkers during COVID for good reason. This is a U of U specific slide. Pre-COVID, our telehealth outpatient visits were at 360 a month, 0.4%. At our peak, we're at 60,000 in just April. That's just the University of Utah. And now we're at a sustained amount of 23,000 monthly. This is parroted by other what are called academic medical centers or teaching hospitals, which is to say that telehealth became very, very common in April of 2020, and then has remained at much higher levels than it used to be. So Through that process, CMS, the Medicare Medicaid funder, allowed a lot of changes. And I know very similar things happened here in Australia. They allowed parity of synchronous telehealth visits, meaning they would pay me the same, no matter whether I saw the person in person or on a camera. And in fact, it was the same even if it was over the phone, which was very helpful because many of my patients don't have cameras. They no longer required the patient to be in a healthcare facility. They could be at home. They suspended frequency limitations, and then they did a bunch of other stuff as well. The issue of me being licensed across state lines remained somewhat murky. It was okay by CMS, but remember I told you states govern licensing, and so that got complicated. And I think, yeah, this is a U of U slide that my friend gave me, and he was just constantly keeping it up to date. What is Idaho allowing? What is Nevada allowing? What is Wyoming allowing? And you can tell requirements and status, trying to make sure that we're all following the law. And it was complicated. Happily, because I do Telestroke, I was already licensed in all those states, so I didn't have a problem. But my colleagues who don't do Telestroke, these were bigger issues for them. All right, the future, what does it hold? I'm no expert, so I'll just show you a couple things that I found and add in some personal commentary. But I think there is a financial integration imperative for Telestroke and telehealth in general to continue in the United States, to move from a fee-for-service to a value-based reimbursement. These are a couple of quotes. For systems highly reliant upon fee-for-service payment, the immediate return on investment from telehealth programs may not be obvious. And I told you that CMS isn't paying me enough to do the work. 80 to 100 bucks is not enough to manage a program or for my time considering what I'm doing. And then limited and uncertain professional fee reimbursement and upfront implementation costs will limit returns for those who do not have a significant value-based reimbursement. So instead, system leaders must evaluate telehealth ability to drive operational efficiencies, improve clinical quality and patient outcomes, and enhance the patient experience. And then each of these can drive financial results. This is a slide from what's called the AAMC, which is the American Academy of, I think it's the Academy of Academic Medical Colleges. I think I have that right. So teaching hospitals, which are slightly different from non-teaching hospitals, but still have the same payers. And they're really saying how you have to integrate telehealth. So it's not just going to be a one-off service. You're going to have a strategic and organizational integration, clinical integration, financial integration, and et cetera, operational and academic and community mission. So that you're really trying to look at this globally and not just like, hey, I have a camera and I can do this. This is an example of a telehealth governance group where you have physician leadership, nursing leadership, legal, financial, research, et cetera. And all of these people are hopefully working together to build a robust program. My hospital is really into the concept of value. And so they created this slide. These are their digital health principles. So exceptional patient, faculty, and staff experience. And then aligned with the system of quality. They always use this formula, V equals Q over C, which I don't think is really a real formula, but it's value equals quality over cost is what they're trying to say. So the higher the value, the higher the quality, when they're trying to obviously reduce costs. Financial sustainability has to be a part of this. And then they really do want to innovate. So they don't want to be stuck in the old ways. There was a slide that my friend gave me that said, if you just slap new technology on top of old ways, you just end up with a really bad organization. And so the idea isn't just to be innovative, but to innovate in a way that is consistent with your goals as an organization. So here's some potential examples of cost savings through telehealth. One is that it may not take as much space to see patients over a camera as it does in person. And so you may be able to expand your clinic utilization if you have the physicians and nurses without building another building, which can be helpful. You can also do follow-up visits via telehealth and then have your new patients, which are generally more reimbursed and will drive up business, replace follow-up with new patient visits. There's some hospitals that have found that remote patient monitoring for some diseases like heart failure will improve outcomes. And so that they will actually offer this free. A couple of hospitals are doing this because it's improving their care and that then will reduce their costs. Similarly, tele-ICU programs, even done internally, so not even to another hospital, but done internally in your own hospital, can reduce operating expenses and lengths of stay and then save you money. This is an example from our own hospital. They're trying to increase retail pharmacy capture And they have estimated that if they capture 1% more, that'll equate to $900,000 a year. And again, that can go back into building more telehealth or into research or into outreach, et cetera. One thing is that we can have problems when you only look at each service line by itself. So you can have returns from a telehealth investment going to one group, but the cost going to another. So stroke neurology, we build a telestroke service, we take the call, but then the patients come to our hospital and it's radiologists and ICU doctors who get downstream revenue. So that'd be one example. Or I didn't get into this because it's really complicated, but we do have quality bonuses that come from CMS to our hospitals. And so if we lower preventable readmissions, for example, for heart failure, we get a quality bonus. And so you might do that by implementing remote monitoring, but then that's not the group that did all the work to do the remote monitoring. So the population health group has the costs, but the hospital is getting the quality bonus. And so really what you want to do is create aligned telehealth funds flow, where you're recognizing what is going on for the whole system and not just dinging certain groups within it. All right, let me see the time. Okay, I'm trying to do this really quick. This was a cool little study that I did 2 years ago and presented at the stroke conference to try to understand a little bit more about maybe cost savings that I was giving to our system or cost improvement. And so the idea is that our hypothesis was that when a telestroke system goes into a hospital, it creates what we call a halo effect, which is where other people think, oh, the U of U is really cool, they have telestroke, so we're going to send patients to them for other diseases as well. So it benefits non-stroke service lines is the concept. And I pared these slides down. I'm not giving you any of my methods, but these were the questions we asked. Does implementation of a telestroke program impact overall transfer volumes, transfers to non-neuro services, severity of transfers, and then the dollar amounts for those transfers? I like this. This is what we found is that for 12 of the 13 hospitals that we were able to study, the volume and trend of overall transfers does increase after telestroke initiation. And this isn't for just stroke. So you can see these two, they were kind of already coming up already and they continued to go up. This one, it reversed the downward trend. This one kept going down, whatever was going on, they still didn't transfer as many patients. And this one had a little weird inflection point there, but no matter where you looked was higher than it had been before. And so we found that the mean transfers per month before and after telestroke partnership went up by actually 30% per annum, which is actually huge. And so again, that's patients coming to our hospital for other diseases. This isn't for stroke. This slide actually shows that, which services benefited and which ones didn't. We have no idea why some services saw more patients than others. I mean, I understand neurology, I understand cardiology, but why behavioral health would benefit or general surgery, I don't know. So it's a little bit unclear to us. I'm not going to get into the severity of transfers and the value other than to say they stayed the same. And so we didn't see any benefit or detriment there. So we found that when part of a larger outreach strategy, telestroke networks can create a halo effect for non-stroke hub service lines by increasing overall transfer volumes. So in conclusion, I think the economics of telestroke in the United States are very complicated. It's definitely a moving field on the backdrop of a sea of change. I think the economics don't balance well using only traditional fee-for-service billing. It's never going to come out in a way that makes us want to do this. And so it has to be within a larger healthcare strategy aimed at population-based health. And you're going to have hospital-to-hospital agreements and then really strong community and hospital support to both increase value and decrease costs. Thank you. Made it.
Thank you, Jenny. That was wonderful. Yeah, you did make a great time, and yeah, wonderful, really wonderful lecture. I would start with a question around the supply side. You mentioned initially in the beginning of the presentation, but also towards the end, probably clarified this point. I would say not only for other services, but also for telestroke, well, stroke-related services, there seems to be an increase in demand. Let's say you refer to that as a volume increase overall. Obviously, you connect that to the point you make around payment models. As an economist, one would say, well, the easy solution, although it may not be politically attractive, it's to allow for more relaxation in terms of sort of training opportunities for people to actually be trained as stroke specialists or neurologists and so on. So a relaxation of the entry requirements to specialize in those areas, which actually do increase also the burden on incumbent physicians, because you have to train them. So the alternative to that model, which probably is not internally appealing for many reasons, including the price of care, it's to open up using telehealth to international markets. This is something that in economics is discussed quite a lot, because that is clearly an opportunity that telehealth offers, which presents a number of other challenges, including quality assurance. If, for example, you have contracts with services that are based in Europe, or let's say similar trained physicians. So I would say that this supply side problem might, in fact, lead to a sort of withdrawal, right, from the physicians themselves. Is it something that in the clinical world you're discussing at all, how to deal with this potential demand increase, and sort of the prediction that it might open up to international competition, or is it something that it's not really yet on the table?
Yeah, so we are addressing the supply side. I actually was heavily involved in the American Academy of Neurology's efforts to come up with some solutions for this problem, for the supply and demand of neurologists. And on the supply end of it, we actually talked a lot about this. One of the things is that, again, CMS is a big payer of postgraduate education for doctors, and which is kind of weird, but anyways, Medicare pays for a lot of our training. And they set limits on how many residents can be trained each year in each specialty. And so we've been lobbying. When I give an advocacy talk, I have a ton of slides on this, but we've been lobbying to increase the number of doctors. It's not just neurologists who are in shortage, there's many others as well. And so we've been lobbying to get more slots. The second thing is then to allow international medical graduates to fill those slots, which we do allow. But then the key is that if they want to stay in the country, they're supposed to go back home to their original country unless they get a waiver, and that waiver is given to them if they work in a rural or underserved area. It's actually a pretty good program. It means we get doctors in places that we don't have doctors. But even here at this map this picture I have on the screen here, we're allowed to have some J1 visa waivers, and I'm trying to hire one right now, actually, for when I get back. So there is some of that going on, trying to increase the in-person presence and the in-person number of neurologists. Of course, it's a long tail, right? This is not a short-term solution. The second issue about allowing telehealth from overseas, I have not heard anyone talk about that if the person isn't licensed. Nobody actually cares where they are. So I could be doing it from here. That would be fine. But you have to have a US license. And that is it's actually pretty hard to obtain, because you have to do your graduate training in the United States. And I haven't seen any suggestion to relieve that or to change that.
Yeah. Okay. It's good. There is a question around the scalability of the programs that you're running in the US, whether you think they're exportable. Not more than that I have in the notes, but
that's okay.
You know.
Well, I think the clinical programs definitely are. I mean, the Telestroke that's being done here is very similar to what we do. It has some differences. I think Carlos is on the call today. But, and so we've been talking about that, like how we differ, but those are minor differences. I think overall it's very scalable. The main thing is understanding your own financial and regulatory environments, because those are so different. And so what incentivizes, I mean, in the global scheme, we're all incentivized by good patient care. I think we're all pretty keen for that, but you just can't make something out of nothing. And so the financial incentives or the regulatory incentives are very clearly going to change from place to place. And so some things are easy in my institution and not here, and vice versa.
Okay. And finally, a question around waiting times and whether telehealth actually has had any positive impact on access to care.
Right. So I think it actually has had a positive impact. It is interesting how few no-shows we have now. So our schedules used to be, you know, you have this really full clinic and you come in and only 70% show. That's 30% of my time wasted, which is unfortunate. And so we're now able to get people in more readily because people, or, you know, get the wait queue down because we're seeing more per day. Telehealth is faster. I mean, you just don't have, I'm not convinced it's better than in-person care, but it is faster. You just don't have the walking, the conversation. It goes quicker. And so I don't have the numbers on it. I will say that. So, although I bet my colleagues do, like our queue and how that's gone, but I do think it's improved it anecdotally.
Yeah, probably they had in mind the Australian setting with the public system in mind as well, which is quite different from the US setting overall. But anyway, thank you so much, Jenny. It was a great talk and lecture, and really appreciate your time. In fact, if there is nothing more coming through the Q&A chat, well, then I really wish to thank you, and we're really delighted that you're here or there spending your time in Australia, and yeah, look forward to reconnecting with you soon as soon as I come back. And I want to thank everybody who participated and those who will participate. As usual, you're more than welcome to watch and then send us questions. I'll try to grab Jenny as we normally do. We have quite a few that look at our videos afterwards and have questions, so I'll try to manage that. Yeah, I wish you a great evening or a great day, everyone. And I remind you to follow us on our web and social media for the next events in June. Thank you so much.
Bye, everybody. Thank you for listening.